All right. Thank you very much, everyone. Thanks for joining the 17th AFOMP's monthly webinar. I'm Ek Hao Ng, the Secretary General of the Asia Oceania Federations of Organizations of Medical Physics. I'll be the moderator for today. So AFOMPs, we're organizing almost every month for the AFOMP's monthly webinar as well as AFOMP's school webinar. So it is our initiative to share and also to in order to improve to share the experiences of our medical physicists in the regions with everyone. So today we are very lucky to have one of our colleagues, Dr. Zulaikha Jamalludin from Malaysia, to share with us about SBRT for spinal metastasis, technological advances, and the physicist's roles in improving palliations. So please allow me to briefly introduce Dr. Jamalludin. So Dr. Zulaikha has been a dedicated medical physicist in clinical oncology and radiotherapy since 2004. She currently serves as the head of clinical radiotherapy and senior lecturer in the Department of Clinical Oncology at the University Malaya Medical Center. In 2021, she earned her PhD in clinical oncology physics from the Faculty of Medicine's University Malaya. In her dual roles, she oversees radiotherapy treatment planning, dose measurements, and quality assurance while driving clinical improvement, engaging in research, and contributing to several clinical trials in radiotherapy. Her areas of expertise encompass brachytherapy, SBRT, in vivo dosimetry, and the radiobiology of hypofractionated treatments. Dr. Zulaikha is also an active researcher, having authored and co-authored numerous publications in her field. So I'm very honored to introduce my colleagues, my friends, as well as my comrades in my workplace to you all today. So without further ado, I would like to welcome Dr. Zulaikha.
Thank you, Dr. Ng. Good afternoon, everyone. So I will share my slide today. Okay, good afternoon. I'm sorry for the delay, for the technical problem that I've been facing right now. Okay, so good afternoon, everyone. So the topic is much more, actually, I've chosen this topic is just, I would like to relate on our daily physicist role in terms of improving palliation in the setting of spinal metastasis. So we know that nowadays the most popular treatment technique that has been proven to be good for the spinal mets is the SBRT. So I'm just sharing what are some of the technological advances that I know, and also that we're going to apply in our center. Okay, so it's much more towards the sharing of the knowledge in this area. So we know that spine metastasis is a significant source of morbidity in clinical oncology patients, which affect around 20 to 40% of the cancer population. And until today, the treatment for the spine mets remains largely with the palliative intent in order to achieve good pain relief in this patient. And also, we want to give a functional neurologic recovery, and also helps to improve health-related quality of life. And at the same time, we would like to give long-term tumor control and also early returning of this patient to systemic therapy. So in this spine metastasis setting, the neurologic and also oncologic considerations has been combined, mostly in order to optimize the preservation of neurologic function and also to achieve the local tumor control. So we go back into the evolution of the spine mets in order for us to really understand what are how does the radiotherapy being significant in the spine metastasis treatment. So started in early 1970s. For all the spine mets patient, what they have to go through is the surgery with the cord decompression without any instrumentation. And from these intervention, the outcome is poor surgical outcomes, in which not much of local tumor control, and also most of these patients also undergo low quality of life. Then starting in 1980s to 1990s, radiotherapy comes in, where we have to deliver conventional EBRT with a dose of typically around 30 gray in 10 fraction. But it helps to improve the palliative condition of the patient, okay, and also it helps to improve the pain control of the patient. But what we found out that with the use of conventional EBRT, it is quite ineffective in some of the solid tumor and also in radio-resistant primary tumor. So starting in mid 1990s to 2007 to the mid 2000 century, what does the neurosurgery take into action is the aggressive surgery with the instrumentation, which they found out that with the surgery alone, it helps to improve the surgical outcomes for these spine mets patients. But in 2005, they started to combine both the surgery and also conventional EBRT, where they found out from most of the clinical trial, when they compare the combination of surgery and also conventional EBRT with the surgery alone or with the EBRT alone, the outcomes will be much more improved in this patient. Okay, so but at the same time, with the advancements in the MRT, okay, so in the year of mid 2000 onwards and also until today, the radiotherapy world itself has been being advanced into the treatment of MRT, and also with the additional of IGRT, we are enabled to give a good radiotherapy treatment delivery to this patient. And with the introduction of the SBRT, where we can give ablative dose to this patient, so it increased further the local control for this kind of spine metastasis patient. And also it allows us to it allows us to send this patient for the re-irradiation with the safe within the safe environment. Okay, so these are the evolution of spine meds, where we can see that throughout the year, the advancements in radiotherapy actually plays a big role in the good outcome to the spine meds patient. And all this is actually because of the evolution of the radiotherapy itself. Okay, and also this is much more related to the dose modulation techniques being improved in the radiotherapy techniques. So again, with the radiotherapy evolution, we started to deliver 2D radiotherapy without any imaging, any 3D imaging for this spine meds patient. Okay, and then we move towards to the use of 3D CRT, where nowadays we have the 3D images, where we are able to see and also to delineate the organ areas and also the tumor. But most of the treatment delivery is being delivered in the 3D CRT era, is being delivered whether with only one beam, posterior beam, direct posterior beam, or with the anterior combination of anterior posterior beam. And then we have advancement in the therapy with the implementation of the MRT, where we are able to give a good conformal dose to the whole target, while at the same time we can reduce more doses to the organ areas. And nowadays, with the use of SBRT, we are able to escalate the dose at certain area within the GTV itself with a very high ablative doses, and this has been proven to give good outcome in terms of good local control in this patient. So with the evolution of the radiotherapy from starting from 2D to the SBRT, we can see that there is a differences in terms of the local control in spine meds, where within 1 to 2 years of local control, the differences is quite huge when we compare between 2DRT and also SRT. Then starting Then when we look at the pain response also, okay, there's a quite huge improvement from the 2D to the MRT and also to the SBRT. And also this leads to the improved durability of the response, which if the patient undergo for 2D and also 3D CRT, it is between 3 to 6 months. Whereas if you are able to deliver SBRT to this kind of patient, the time of durability of response will be much more higher. It will become more than 1 year. So this has been proven in numerous randomized clinical trial, okay, where we can find the accumulation of all these randomized clinical trial being produced in this paper, where you can see that the 3 months control rate for these patients when compared between SBRT and also the conventional EBRT is much more higher with the higher SBRT. So these confirm that with the use of advanced technique, we can give much more complete response and also local control to these kind of patients. But there is a pro and also cons with the advanced technique, which I think most of the physicists known about this. So it's just a recap or a summary on the pro and cons between evolution from 2D to the SBRT, where we know that in the 2D era, it is a simple setup and also short planning time, but with the disadvantage of poor conformity of the doses surrounding the target, and also that is a very high organ at risk dose. And the most important thing is it was found that that with the use of 2DRT, it is quite ineffective for the radio-resistant tumors. So in the era of 3D CRT, we found that the dose will be much more better than the 2DRT, but still it doesn't give any significant difference in terms of the local control between 2D RT and also 3D CRT. But the advantage in the MRT is we are able to deliver a very high conformal dose to the target volume, but with the disadvantage of it requires longer planning time and also longer QA time, and also a bit of higher low dose bath area within the normal tissue. And with the use of SBRT, now we are able to deliver the ablative dose. Okay, at the same time, we are able to produce a steep dose gradient. We can reduce the dose quite steep to the moderate risk. Okay, but again, the disadvantage is much more longer planning time, and also not to mention also the intensive QA that we need to spend, okay, to ensure that the SBRT treatment is being delivered safely. And also the additional time during treatment delivery is the image guided radiotherapy, where it will being added into the total treatment delivery time. So we can see that from these at evolution of 2D to the 3D, the MT to the SBRT. So what are the significant difference is the increase in complexity and also increase in the time from the simulation to the treatment itself. Okay. So, but we know that from all these published and also proven data that showing that the IMRT and also the SBRT can give a good local control. So in spine meds patient, what we want is we still want to be able to deliver and also being able to produce a good local control within this patient. And at the same time, this can be achieved only if we are delivering very ablative dose. So we want this in this spine meds patient. At the same time also, we want to be able to deliver the radiotherapy treatment in a safe environment. Okay, but the most important thing is in order for us to get all these good local control, ablative doses, and also safe delivery, not to mention also we want the simulation to the treatment time to be as short as possible, because in this spine meds patient we have to remember that all these patient comes with with some neurologic symptoms, and also some will come with a pain score of between 7 to 9. Okay, so we need to make sure that we are delivering the radiotherapy treatment safely, but able to give ablative dose in order to get good local control. But at the same time, we want to the simulation to the treatment time to be as short as possible. So STT, the simulation to treatment time, where we know that with the delays in the treatment, this will impact the quality of life, and also it is less ideal for patients that comes with high pain score. And some of the delay factors is because from the simulation procedure itself, okay, and also from the target and OAR delineation, and for the treatment planning, because it really depends on the complexities of the cases, okay, and also the type of radiotherapy treatment delivery that we choose, whether it's MRT or SBRT, and also with the use with the implementation of the MRT and SBRT, we need to do the patient or plan specific QA. So all this will include into the elongation of the time from the simulation to the treatment. So now we are thinking whether we can perform the simulation and the treatment in a day. So can we do that? Okay. So from previous, I mean from the available literature, and also maybe from the experience of other center, okay, it is possible to do a simulation and also the treatment within 1 day. Okay, but what so from all these center, what they did is they call it as sim-free radiotherapy technique. Okay, where in this session, where in this center, most of them make use of the diagnostic imaging to come up with the dose calculation and also the treatment plan. So what the treatment plan has been planned prior to the patient visit, prior to the patient coming to the department. So once the patient comes to the department, the only thing that they need to set up the patient is they will set up the patient directly on the couch, on the treatment couch. Okay, and what they will do is the verification using the CBCT, and then match the CBCT with the diagnostic imaging that was used for the treatment plan. And what they found out that the median time plan generation is much more or less with the use of this technique, with the use of the sim-free technique, compared to the conventional procedure, where the patient needs to come for the simulation and then go back and then give us some time to come up with a plan. So but the total treatment time will be escalated a bit because of the duration to take the CBCT, and also then to match the CBCT with the treatment plan, and also to recalculate back. Okay, but it is doable. So from this study, they come up with the randomized clinical trial, okay, which they call as DART. Okay, and now they have been able to publish the outcome of this DART, the result of the randomized trial in the palliative setting for this sim-free 1 day 3D-RT technique. And with the primary endpoint was the time this patient spent in the center. Okay, and they found that that the TIC, the time in the center, was only maybe half. It is less than 2 hours being spent. The patient spent less than 2 hours in the center for the sim-free, and then until to the end of the treatment itself. Okay, so now it shows to us, it's proven to us that in palliative setting for the 3D-RT, we are able to do to deliver the treatment delivery within a day, and also without any simulation being taken into account. So now from a day of simulation to 3D-RT treatment delivery, now we are thinking of whether we are able to do the simulation to MRT treatment delivery in a day. So can we do that? Okay. And also this has been proven by some of the center. So this comes from the Amsterdam University Medical Center, where they managed to perform the SIM-free. So the patient so they make use again the diagnostic imaging to do the planning. Okay, so that the patient, when the patient come, the patient just lie on the treatment couch. Okay, and then they just deliver the IMRT treatment on uh, uh, on the day of the patient on first visit itself. Okay, so so these are the results from their trial, which they call it as FastMed study. So you can see that most of the patient, okay, the patient only have to spend less than 2 hours in the radiotherapy department, okay, for the simulation free, and also until to the end of the IMRT or VMAT radiotherapy treatment delivery. Okay, so it's shown to us that these are being able to be delivered or to be implemented with the use of the advanced technique, where in this center they make use of their ethos or adaptive modality to treat the spine mets patient. So in conclusion, so they conclude that this fast treatment workflow for patients being referred for painful bone mets can be implemented successfully using the online adaptive radiotherapy. So now with the ability to perform the SIM to IMRT in a day. So now people are thinking about whether we can do the simulation to SBRT treatment delivery in a day. So can we do that? So I managed to find one center, okay, that they are starting to offer the simulation free SBRT for bone mets, okay, but there is no outcome yet from this project because they just started. They just managed to come up with the standard operating procedure, and also what are some of the challenges to implement this, and we hope to see the impact or outcomes from this study, so that we hope in the future we are able to learn from them and also implement it in our center. So it's quite fascinating to wait for this outcome. So looking back at the as IMRT and also SBRT for the spine in one day, okay, day itself, okay. So we are looking at reducing the total days from the simulation to the treatment delivery. So it is good for the patient, okay, but in one study they found out that the staff stress level is getting more higher, and I think most of the physicists will admit that in order to finish the planning and also the QA within the simulation day itself to the treatment delivery in one day, it's quite stressful. So talking about stressful, actually this is where the automation and also AI will comes in and also will help us to reduce the stress level, while at the same time help us to make sure that we can achieve these SBRT spine or IMRT spine in a single day from simulation to the treatment delivery. So there is the need for automation and AI in the text of the contouring, in the text of the treatment planning, and also in the context of the patient specific QA, which I believe that the automation and AI will play a big role in these three procedure and also in these three steps of any SBRT, not to mention SBRT spine, but in any SBRT treatment for different sites also. So we look at specifically for the SBRT spine. I think one vendor managed to come up with the automation and also with the auto contouring of the spine SBRT target itself. Okay, so I think yes, this paper has been published in 2022 with the Brain Lab managed to come up with the automatic generation of the CTV based on the gross tumor volume itself. Okay, and what they conclude is with the use of this segmentation tool for spine SBRT, the idea is to make use of these auto contouring as the first step for spine SBRT target delineation in order to improve the contouring consistency between different clinicians and also between the different centers, and also as well to reduce the contouring time. But I have to admit that my center doesn't have this. Okay, so in terms of contouring, in terms of the contouring of the target volume, we are still relying on the clinician to take their own time to come up with the contouring. But we try to make use of auto contouring for all the organ at risk nearby the target volume. So that one is on the contouring. So how about the treatment planning? So the automation and also AI in the treatment planning in the world of SBRT actually are now being given quite focused attention. So in a systematic review literature done by this person Robinson and also Gleason, okay, so they come up with a systematic review on the topic of whether we can use a knowledge-based planning system to improve the SBRT treatment planning. So based on that, there are quite 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 a number of paper that has been cited. So I just take the papers that related to the auto planning in the spine. So until today, the system that make use of knowledge-based planning for the automation of the treatment planning is being used by the Eclipse Rapid Plan. And there's only 3 studies that have been conducted for the spine side, and these 3 make use of less than 50 number of cases to train their model, and also less than 20 cases to validate the model. And in one paper, they found out that the use of knowledge-based planning can reduce the total planning time from 1 hour, from 1 to 2 hours to less than 15 minutes, less than half an hour. Okay, but at the same time able to give a quite good plan quality being produced with the use of KBP compared to the manual planning. um, and but what is most important is the use of KBP, the knowledge-based planning, has been proven to have the potential to improve the quality, and also the most important thing is the speed of the stereotactic radiotherapy planning. But bear in mind, until today, there's only little research on this knowledge-based planning, especially for the prostate, spine, and also liver SBRT. So I think these give quite opportunity for research to be conducted in this for this side, especially among the physicists, so that we would be able to improve more on this automation and also AI in treatment planning for this side. So so another automation and also AI that can help to reduce the simulation and also from the SIM to the treatment delivery is the patient specific quality assurance. So we know that most of our PSQA have been conducted with the use of measurement based method. So, and also I think we as a physicist, we know that this measurement based based method is a time consuming, and also it's quite burden because you need to set up the phantom, the detector. But still, what is important that the data, the evaluation is based on 2D based evaluation. Okay, so nowadays people are moving towards the calculation base, where these are the kind of 3D based evaluation. Okay, and also it make use, instead of using the detector, it make use of independent dose calculation algorithm to verify the planning, to verify the quality of the planning. and and at the same times, we also have the log file trajectory based quality assurance. So it is a kind of mechanical and also data integrity evaluation, which make use of the daily log file. And now with the AI coming in, the trend also now the research, I think most of the research nowadays in patient-specific quality assurance are based on the AI-based, where the machine learning and also the deep learning, the conventional machine learning comes into the picture. And but it makes use of all kinds of data to model, to test, and also to validate this data. But I think in at least for my center, we don't this we make use of log file, but in terms of to shorten the treatment delivery, to shorten the time from the sim to the treatment delivery, we make use of this calculation base to help us to improve more the STT in the spine meds patient. And these, and also you can combine between all these available types of patient specific quality assurance method. So this paper highlight that we are able to hybrid the use of a 2D method and also 3D method in performing our patient specific QA, so that we are able to reduce the time that we as a physicist spend to perform this patient specific quality assurance. So by combination, I hybrid the PSQA technique with the use of the dose calculation method and also the 2D method. Okay, we are able to improve more, and the whole radiotherapy process, whether it's MRT or SBRT in our department. So so these are another paper. Actually, these are based on this paper that our center come up with, reducing the timeline from simulation to the treatment delivery, with the combination of whatever automation and also AI that are available in the department. So from this study done by, if I'm not mistaken, done by the one of the US center, they still perform the CT-based simulation, okay, and they generate the CV and also OER convert as normal, but the automation and also the AI comes in with the use of the scripting, okay, scripting method in the planning, okay, and also with the use of the calculation based verification, the 3D PSQA method. So they estimate that for all the cases, for all the spine meds SBRT cases, the simulation to the treatment time can be achieved within 2 to 4 hours with the help of the automation uh, and also AI in some of the step of the treatment planning step. Okay, so they conclude that with the use of this AI and also automation, it can expedite the treatment delivery, especially in a patient that comes with some neurologic symptoms, which we need to treat them as soon as possible. So I think I have come to the my last slide. Okay, so my key takeaways for this is, I think we need to change our mindset. So palliative intent does not mean limited technology. So, and this is because there are so many evidence that support the use of advanced technique, which can significantly improve the pain control, the local control, and also the quality of life of our patient. And but the most important thing is we as the medical physicists, we must lead this shift from 2D or 3D thinking to precision based approach, the MRT and also the SBRT, which this will ensure the palliative patients benefit from the use of state-of-the-art tools available in our radiotherapy world. So physicists, we need to actively advocate in clinical decision making and also in the planning workflows, which again, this will give benefits to the patients, whether it is a palliative or palliative intent, and with and it is thought, and I think it's quite important to think that the palliative care deserves precision too. So with that, I think yes, that's all from me. Thank you.
Thank you very much, Dr. Zulaikha. Yep, there's a wonderful presentations and a very comprehensive about the roles of medical physicists, what we can do in terms of the SBRT for spinal metastasis cases. So I totally agree with you. From this 3D to IMRT to SBRT, we wanted to see that you have a good local control, ablative doses, and also safe delivery to the patients. But most importantly, that you have shown to us that there's a game changer here, which is a short simulations to treatment times, all within a day. So that is fantastic if that is possible to be done. So I totally agree with you that the involvement of these medical physicists is crucial, together with our oncologists, technologies friends, to provide this timely management to improve the pain control, the local control, and to improve the quality of life of the patients. So I'm sure that everyone will agree with me that we play an important roles to ensure that our palliative patients benefit from these advanced techniques. So now I would like, we have some time for the question and question sessions. I would like to open the floors for the Q&A sessions. You may either put your questions, type of questions in the chat box, or you can unmute yourselves and ask the questions directly to Dr. Zulaikha. Maybe I'll just start the ball rolling. So yeah, I think everyone will be very impressive that the technology that Dr. Zulaikha have shown us just now, it involves quite a lot of technology. I just wondering if I'm working in a humble radiotherapy center with one gantry-based LINAC, what are the essential components or the facility for me to start this procedure?
Okay, so if you have one linear, I think our department also now living with one LINAC. Okay, so the first thing that the most important thing I think in if you are if we want to reduce the simulation to the treatment delivery time, first we need to know where does the time delays comes from. So if the simulation doesn't if I mean I'm speaking from my experience, most of the time delays comes from the planning itself, because we want to produce a quite complex IMRT or SBRT plan. So it really depends on the physicist skill. So we started with a template based IMRT for spine mats or SBRT for spine mats. Okay. Then from that template base, we make sure that we try to train most of the physicists to come up with the treatment plan that following this template. So by making sure that they are following the template, you can make sure that first, the quality of the treatment plan, and also second, you can control the timing of the treatment plan itself. Then second, I think, is the patient-specific QA, okay, which it really depends on your center. If you are able to use if you are able to have time to use the LINAC to perform your patient-specific QA during lunch hour and also after at the end of the day, then you I think it's quite possible for you to shorten the simulation to the treatment delivery time. So from my experience and from my advice, if you have only one LINAC, okay, it really depends on the number of your cases being treated in the LINAC. But what is the most crucial, I think, is on the planning, okay. So if you can come up with a template base or scripting for the automation, okay, and also if you are able to proactively improve your patient specific QA time, and also the way you handle your PSQA. So it's not about the LINAC. You are having only one LINAC. It's about the planning process itself before you send the patient to the LINAC. So the preparation of the treatment delivery is the bottleneck of the in order to ensure that you have a shortened time window from the scene to the treatment delivery.
Yeah, I totally agree with you. I think with the advancement of the treatment planning system that you can do scripting, as what mentioned by Dr. Zulaikha just now, the scriptings, all these AI automations process in terms of the treatment planning, that will really help to escalate or to accelerate the process along the workflow. So, right, so what about if the center only have a tomotherapy? Is it also a matter, or it doesn't matter at all, in your opinion?
I'm sorry, I don't have any experience with tomotherapy, but again, I strongly believe that it's not about the machine, it's about the planning process. So as long as you are able to shorten your treatment planning and also your PSQA, I think it's doable. Because right now, to be honest, our center have eclipse of the older version, okay, which by we don't have any GPU. By right, with the what I know from my experience, when I go to other center that already have the eclipse version 15, those calculation is quite fast, the optimization is quite fast. But surprisingly, that is what that's what is most important, is the skill and also the template base. So in our center, we have Eclipse version 13 without any GPU, but we are able to come up with the SBRT spine meds plan within 1 day. So now our simulation to the delivery time for SBRT spine will took around only 3 to 4 days, okay, compared to previously when we started. It took us around 10 working days to from the sim to the treatment delivery time. So yes, I still believe that if we have more advanced tools, we are able to do it in 1 day, like what have been shown by other center.
Yeah, totally agree. So I think this is actually the concerted effort from all the radiation oncology professions, medical physicists, oncologists, and others to make it possible. So, Dr. Zulaikha, how about in your experience, are these kind of cases for these spinal meds cases, are these the prescribed dose the same with the others SBRT spine? And how about their dose constraint for the spinal cord? Are they the same as in the typical as the others?
I mean, the difference between IMRT and also SBRT is the only ablative dose within the PTV. So, but in terms of the spinal cord tolerance, whether you are delivering, regardless of what are the prescribed dose, the tolerance for the cord will be the same depending on the number of fractionation. So like let's say I take two fraction SBRT for example. So let's say the prescription is 24 into 24 gray into fraction. So the spinal cord tolerance is 17 gray. Let's say in other center, the prescribed dose they escalate up to 30 or 28 gray into fraction. Still the prescribed still the dose tolerance for the spinal cord is still the same, 17 gray. So the number of fractionation, it really depends on the surrounding nearby organ areas, and also depending on the patient's condition itself. So this decision will be made by the oncologist. But what we need to understand and also what we need to know is how to paint the dose in order to give a good ablative dose and also good dose coverage to the target volume.
Yep, agree. We got a questions from Yuan Xing Teo. Planning skill is very important. By using template is good for standardization. But if the medical physics don't know how to play around with the TPS function, it will also affect the planning time and plan outcomes. Okay, so it's a comments from Yuan Xing. Yep. There's a yes. This is one of the skills that we really need to master in. And my trial was also giving a comments and also questions. Thank you for your great presentation. At our hospital, we have a TrueBeams SDX and are planning to start SBRT for spine metastasis. Could you recommend any standard guidelines for a new center starting SBRT for spinal metastasis and share any advice based on your experience? So we've been talking about it just now. Ika, would you like to add on anything else?
Okay, thank you for the question. Okay, so the European guideline I think they just published the guideline on the SBRT spine. Okay, um, last year or last 2 years if I'm not mistaken, but you can find it. So based on this guideline, they come up with what are the minimum requirement that the center should have in order to start the SBRT spine. So you can check within that guideline what are the kind of what are the tools and also the kind of treatment planning system that is have a minimum requirement, and you can check with your center whether whether your center fulfill the requirement in the guideline. So that is much more on the general guideline. But in terms of the dosimetric guidelines, you can refer most of the SBRT for spine, okay, um, is being led by two quite famous clinician. So you can find if you Google, you can find papers from Sagal, Sahgal, and also from Matthias Guckenberger. So these two people are the pioneer and also the most popular person that prepare the guidelines in terms of the general guidelines and also in terms of the dosimetrics for the SBRT spine. And also the third person is the Timmerman. So I think for those center that wants to offer SBRT spine, you can Google for these three names. Okay, Sagal, Matthias Guckenberger, and also Timmerman. And also for us as the physicists, we need to refer to the AAPM guideline on the stereotactic for a physicist guideline. So it's quite important for us to understand the requirement for the treatment planning and also for the PSQA, because we are talking about small field dosimetry.
Thank you. Yeah, due to time constraint, we are taking the last questions for today. So I'm interested in re-irradiations for spine SBRT. Could you provide an example on how re-irradiations is done and what factors should be considered for the case. Questions from Rakasan.
Okay. So re-radiation is something that now, because of the advancements in technology, the patients leads more good quality of life and also live longer. So and also for SBRT spine, we really will expect that the tumor will come back again, because we are with the use of SBRT, we can deliver ablative dose to the target volume, but we have to respect the dose to the spinal cord itself. So for those tumor that is really near to the cord and also already impinge the cord, we cannot give good dose over there. So that is why we definitely are going to expect that the tumor will come back. So the re-radiation setting in spinal SBRT is quite common. I can say it's quite common nowadays. So there are many I mean, it's not many guidelines, but there are certain guidelines on this. So again, for the re-radiation in spine SBRT, the popular guideline comes from the SAGAL, again, okay, from the SAGAL, and also from the European guideline on the spine SBRT radiation. But most important thing is the factors that we need to consider is, I mean, beside from the clinical oncologist decision, because they are the one who decide whether the patient are suitable for the radiation or not. But we as a physicist, we need to consider in terms of the previous dose and also the contouring and also the setup for the previous treatment delivery. So it's good if the re-radiation was done, the re-radiation will be delivered in the same center. But let's say, because like us, I'm working in a government hospital, so some of our patients sometimes they have received previous SBRT spine in other center. So this is where the physicists need to communicate with the physicists in other center in order for us to really be able to retrieve back all the radiotherapy information, the setup, the dose, the DVH, the previous plan. Because you need to take into account all this when you need to come up with your re-radiation treatment plan. And the most important thing is now for re-radiation setting is it's not just you want to continue to give delivering good local control, but the priority is much more on the safety for the second irradiation. So I think you can find it in some of the papers, but if you want, I can also share with you some of my papers and also literature review and also our guideline for re-radiation setting.
Thank you very much, Dr. Zulaikha. I think there's a very comprehensive Q&A. I think, okay, so now I think it's about time for us to conclude the meetings. So first of all, thanks to the speakers, Dr. Zulaikha, for these wonderful talks. Thank you very much for spending your time with us these weekends, afternoons, and also thanks to the ETC, PRC, and also SC of the AFOMPs for organizing this AFOMP's monthly webinar and inviting both of us to moderate and also presenting this work from Malaysia. And also, of course, thanks to all participants to be with us at these great afternoons. And with that, thank you very much, and we hope to see all of you in the next AFOMP's monthly webinar or AFOMP's school webinar, and hopefully to see you in the Adelaide for the World Congress of Medical Physics and Biomedical Engineering in 29 September to 4th of October in Adelaide, Australia. So is there any officers will take over the meetings or I should conclude? Right, maybe we just conclude the webinar for today. Thank you very much, everyone. Have a good day. Bye.